Hi everyone. Mackenzie, Olivia, and I will be presenting for you ulnar nerve entrapment. Ulnar nerve entrapment is a numbness or paresthesia of the hand, which, if left untreated, can lead to weakness and atrophy in the medial portion of the hand near the fifth digit. This is caused by a compression of the ulnar nerve as it travels along the arm. It is typically compressed at the collarbone, elbow, or wrist. One of the most common sites of irritation and compression is at the elbow in the cubital tunnel. The image on the left gives a good visual representation of the location symptoms will typically occur. The image above gives a visual of the brachial plexus and shows where the ulnar nerve will travel. The ulnar nerve travels from the neck through the length of the arm. It originates from the roots C8 and T1, where it turns into the inferior trunk, which then branches into the medial cord. The ulnar nerve is a branch of the medial cord of the brachial plexus. As the ulnar nerve travels down the arm, it passes by the posterior medial aspect of the humerus. It then travels behind the medial epicondyle of the humerus and passes underneath the muscles of the medial aspect of the forearm. Finally, before it reaches the hand, it passes through Guyon's canal, which is a second tunnel located at the wrist. Before the ulnar nerve enters the forearm, it passes through the cubital tunnel. This is a spot where the humeral and ulnar heads of the flexor carpi ulnaris muscle runs. These two muscle heads are connected by a ligament called Osborne's ligament. This forms the roof of the cubital tunnel. Most physicians agree that Osborne's ligament is the cause of the irritation and compression of the ulnar nerve, and thus is responsible for causing the patient's symptoms and problems. The ulnar nerve is responsible for innervating many different muscles in the upper limb. It innervates the flexor carpi ulnaris and one half of the flexor digitorum profundus in the forearm. In the hand, the ulnar nerve innervates the adductor pollicis, the dorsal interossei, the palmar interossei, the medial two lumbricals, the hypothenar eminence, opponens digiti minimi, flexor digiti minimi, and abductor digiti minimi. Sensation of the fifth digit and the medial half of the fourth digit are innervated by the ulnar nerve as well. This is shown above in light blue in the image on the left.
There are many different causes of ulnar nerve entrapment. In some cases, the nerve slides out from its position behind the medial epicondyle when the elbow is bent, causing irritation to the nerve over time. Putting pressure on the elbow over long periods of time can subsequently put pressure on the nerve, and fluid buildup in the elbow can cause swelling that may compress the nerve. Some risk factors that make these scenarios more likely are prior fracture or dislocation of the elbow, bone spurs or arthritis of the elbow, cysts near the elbow joint, or repetitive or prolonged activities that require the elbow to be bent or flexed. Symptoms of ulnar nerve compression have an insidious onset that typically begins with numbness and paresthesia over the small finger, ulnar half of the ring finger, and hypothenar eminence. These symptoms can come and go. They happen more often when the elbow is bent, such as when driving or holding a phone. Weakening of the grip and difficulty with finger coordination, such as typing or playing an instrument, may occur. These symptoms are usually seen in more severe cases of nerve compression. If the nerve is exceedingly compressed or has been compressed for a long period of time, muscle wasting in the hand can occur. There are a couple different tests for ulnar nerve compression, including Froment's sign and Wartenberg sign. Froment's sign is a physical examination where a patient is asked to hold a piece of paper between the thumb and radial side of the index finger to isolate adductor pollicis, which is the only muscle of the thenar eminence that is solely innervated by the ulnar nerve. Flexion of the thumb at the IP joint to utilize flexor pollicis longus rather than adductor pollicis, as well as weakness of the adductor pollicis, indicates dysfunction of the ulnar nerve and constitutes a positive Froment sign. Wartenberg sign is another test for ulnar nerve motor weakness where a patient is seated with their hand on the table and the clinician passively abducts the patient's fingers, then asks the patient to adduct their fingers back toward their middle finger. If in doing this, it is found that the small finger is unable to adduct This is known as a positive Wartenberg sign. This finding represents a deficiency of the palmar interossei, which are innervated by the ulnar nerve and function to adduct the fingers.
There are multiple surgical and non-surgical treatment options to mediate ulnar nerve entrapment. Some methods include physical therapy, occupational therapy, splinting, and in more severe cases, surgical intervention. These options also depend on the etiology of the compression. So, for example, if there was a broken bone that caused the compression. So, less severe cases of ulnar nerve entrapment can be treated with just some anti-inflammatory drugs and an occasional steroid injection. Go the splinting route. Splinting consists of 20 days of elbow flexion with the forearm in neutral position and padding in the splint. This is shown on the picture. Next, occupational therapy emphasizes ergonomic upper extremity positioning as well as strengthening exercises. Here are a few examples of nerve gliding exercises that can increase range of motion and reduce pain on site. Surgical intervention should be a last resort treatment option if all other options have been unsuccessful. There are multiple surgical options available depending on compression location, as each individual is different. The principle of surgical treatment is ultimately to decompress the nerve by removing any pressure that is applied to the nerve either at rest or during movement. There are many surgical treatment interventions, such as on-site decompression, medial epicondylectomy, or ulnar nerve transposition. First, we will discuss on-site decompression. In this procedure, the nerve remains in its location while all sites are decompressed. An incision is placed between the medial epicondyle and olecranon. The cubital tunnel retinaculum, or Osborn's ligament, is divided to expose the ulnar nerve. Further release includes incision of the fascia between the flexor carpi ulnaris or distally through the flexor pronator aponeurosis. Advantages of this procedure include its simplicity and lack of post-operative immobilization. However, if there is an inadequate decompression, revision surgery may be necessary in the future. A medial epicondylectomy is another surgical procedure that releases the ulnar nerve. The procedure includes the osteotomy, or removal of part of the medial epicondyle to release the ulnar nerve. The steps are shown in the diagram. First, there is an incision of the medial epicondyle, and the ulnar nerve is then exposed and released by cutting the cubital tunnel. Muscle attachments are carefully elevated off the medial epicondyle in order to remove part of the bone, and finally the muscles are sutured back onto the cut bone. Advantages of this procedure is that there is less risk of ulnar nerve injury, but disadvantages include tenderness at the elbow as well as less elbow stability overall. The last surgical procedure that will be discussed is ulnar nerve transposition. In this, the ulnar nerve is relocated from behind the medial epicondyle to a more anterior position, specifically superficial to the flexor pronator origin. A fascial sling is created to further prevent nerve migration, and this places the nerve in an ultimately less vulnerable position. However, this is a more demanding procedure compared to the other two.
This concludes our presentation on ulnar nerve entrapment. We hope you learned something, and thank you for watching.